Start off with our pitches. So again, as a reminder, over the past 48 hours, we've had several teams working on ideating solutions to problems in acute care, looking at both hardware and software style solutions. And we're really excited to see what you all came up with today. So we'll start off with a brief lecture and then move into the pitch competition. As soon as that ends, we'll have a break for lunch while the judges deliberate, and then we'll announce the winners at 3 p.m. So the pitches will last probably about an hour and a half to 2 hours. We'll have a little bit of a break, but then come back here at 2:45. We have a lecture from last year's Hacked winner, and then we'll announce the winners for 2024 at 3 p.m. All right, so it's my honor to introduce you to Dr. Jesse Pines. Jesse is the Chief of Clinical Innovation at US Acute Care Solutions and is going to talk with us about innovations in acute care, AI, and beyond. Really a legend in the field. We're honored to have him. Thanks for joining us, Jesse.
Great. Thanks so much, Nick. And again, a pleasure to present here. So what I'm going to talk a little bit about is just a general ways to think about innovations in acute unscheduled care. And so again, one of the ways to think about, if you want to innovate in acute unscheduled care, the best way to think about it is from the patient perspective. And I think, in my experience, that's really the one that really holds the most weight in terms of, how do we solve a real problem from the patient perspective, and then specifically once you've identified a very specific problem, how do we improve on that improves care in the emergency department, improves the efficiency of care, and then it improves something, some sort of measurable feature of acute unscheduled care. And a good way to think about sort of, innovation is there are some things from the patient perspective that work really well in our acute care system. Specifically, when people come into the emergency department, hospital, 24/7 service, they can get pretty much, full workups for, whatever their needs are. They see highly trained clinicians. They have access to leading edge surgeries, consultants, especially in large centers, they can see specialists, often 24/7. And then the system is really open to anyone, regardless of their ability to pay. But when it comes to innovation, it's not necessarily about, elevating the things that we do well. It's about fixing some of the problems that patients face, and there are many of them. One is there's often really a minimal focus on the prevention of acute illness and injury. We see patients once they get sick, once they're injured. Second, patients often have really little direction in terms of where and when to seek care. That's a big issue. Sometimes they'll end up in the wrong part of the system, or not come to the emergency department when they actually need to be there. Navigation is terrible, especially when it comes to figuring out where you need to go and where to go afterwards. From a patient perspective, having family members with some very complex medical needs and having to navigate for them, it's a very non-user friendly system. Two, there's also a lack of price transparency. So patients don't know what things are going to cost. There's price transparency in some parts of the system, but not others. And then often quality of care is variable from setting to setting. So the care you may get from one emergency department to another emergency department could vary dramatically. And even within that emergency department, it depends upon who you see. And often that quality of care is really invisible to the patient. And they don't really know that whether or not they got the right thing. I mean, if they've got some untoward outcome, let's say they're discharged home and they have a problem, then and it may be obvious that the wrong thing happened, but often whether or not the emergency physician did the right thing is often invisible to the patient. So how do we take some of these issues and innovate. And there are sort of two general approaches that the way that I think about things. One is about, quality measurement and feedback, sort of a standard QI approach. And then secondly is the use of new technology and communication platforms. I don't want to put sort of too much focus on that, because often, there's so much that can be done in the first phase. However, you walk around the exhibit hall here, and there are some really amazing technologies here that I think will be in place 5 years from now that will have transformed the way that patients get acute unscheduled care. So the question is, when it comes to prevention, you're a patient, you're an emergency physician in a hospital, how does an individual emergency physician address the quality of care that the patients get when it comes to prevention? And, you sort of think to yourself, as sitting in the ED, isn't illness prevention shouldn't this be the role of primary care to do this? So here's the first area I wanted to think about, which is an area from the patient perspective where there are a lot of inefficiencies, and this is frequent use of the emergency department. And what we see, so frequent users account for about a quarter of our visits, and these are patients who are coming back over and over again. And there's, this is just one study, again, some older data, Medicaid patients from 2013 to 2015. In general, at least in this population, you see patients who are more like, frequent users are more likely to be females, African American, homeless, and again, this is going to vary by community. But in general, you're going to see sort of more comorbidities in that population, and commonly when it comes to what I call persistent frequent ED use, you sort of have this synthesis of medical illness, substance use, and mental health together. That if you have all those things, if you have diabetes and schizophrenia and a drug problem, you're going to be in and out of the emergency department over and over again. Those people often will have a lot of the economic issues. But when it comes to solving frequent use, this is an area that I think we've talked about, but really there's no broad solutions to this. But there is a lot that we can do in the emergency department, specifically with case management, individualized care plans. You sort of look at the literature in this area, and there really are a lot of things that we can do as emergency physicians on the front line to affect frequent use. Next is trying to figure out where people need to be. I've spent the last 20 years post-residency as an emergency physician trying to educate people who live outside the emergency department that people are not unnecessarily in the ED clogging the system. And the issue is that people who come to the emergency department really think that they have an emergency. That's why they're there. They're not there to abuse the system. And this is something you should look at. Empath study from 2005 that sort of did this big factor analysis and figured out why people use the emergency department. And this is the reason. So people think that they have a medical emergency. They think the emergency department's the right place, right or wrong. They're worried about the problem. They're too sick to go elsewhere. And often for a lot of people, there's no other place but the emergency department to be seen for care. So how do we improve patient choice? Again, this big problem in terms of inefficiency of, people. Some people come to the emergency department who don't need to be there. Some people don't come to the emergency department when they need to be there. Pre-ED telehealth is an area that is, I think really could be leveraged. Several years ago, I did a project with Kaiser System. So Kaiser has a sort of an on-call model where they've got one phone number that folks can call, whether or not you've got crushing substernal chest pain. Hopefully you're going to the emergency department, or you're lost on the way to your dermatology visit and you don't know how to get to the doctor's office. There's like one phone call, one phone number, and you can help improve patient choice where they can direct the patient to the right place. And then third is really improving patient education. And I think that this is something that that we as emergency physicians can do in a very positive way when it comes to figuring out where people need to be, and even being available for our patients in relative real time. Second, the next area is enhancing acute care delivery, and this is an area that I've really focused on a lot in the last several years. And when it comes to the sort of the four areas you think about for an acute care problem, you want to think about first figuring out a way to measure something important about acute care delivery. On the right here, this is a project we did several years ago. John Osvarak, who just stepped away, where we looked at opioid prescribing, and we were trying to impact whether or not physicians prescribed opioids at discharge. Our rate was the opioid prescriptions per 100 discharges, and pre-intervention it was about 10 per physician, 10 per 100 discharges. But there was this huge tail where the highest person in our organization was prescribing about 60% of their patients opioids at discharge. So what we did is we created an audit and feedback program where we actually called all those physicians and had a 15-minute conversation with them. And we sort of had a number of different levels of intervention. We actually first, gave the list of high prescribers to the medical directors, where we really didn't see a whole lot of impact. But once we started doing the actual clinician feedback, we saw a dramatic and temporal decline in opioid prescribing. And sort of taking this out to today, our company is at about a little less than 6 prescriptions per 100 discharges. And the total number of outliers, so basically we said 20 or higher is an outlier, has been reduced from 350 clinicians to 2. So it's 2 left. Been incredibly effective. So what do you need to do this? You've got to be able to do the audit and feedback, look at the outliers, and have really good data. Okay, next, when it comes to AI. This was a graph from a paper that my fellow published last year that basically takes from symptoms to discharge and to post-ED follow-up and some administrative ways we can use AI. You'll walk around, there's tons of companies here that are promoting AI. We are at the 1.0 stage of this. The way at least I think about it is sort of 3 levels. The 1.0, which is around ambient, which is, we're just at the precipice of getting ambient installed in some of our emergency departments and testing the impact of that. 2, that I've seen several companies do this, is around charting summaries and essentially going through all the old data in the EHR and actually summarizing what the relevant information in the context of why the patient is there. That is incredibly helpful for us. Incredibly helpful. I haven't seen this leveraged yet at real scale in the emergency department, but I do see that as really sort of the 2.0 version of this, and I have seen some companies addressing that. And then the 3.0, I think, is around clinical recommendations, and clinical recommendations are an area where some people are already doing that, where they're taking the patient's wacky labs, copying and pasting those into ChatGPT and saying what's wrong with this patient. And actually, ChatGPT gives you some good ideas that you didn't think about. But doing that, with a company involves FDA software as a medical device. So it's sort of unclear how all that's going to work. But what I can say about AI, I think it's going to be transformational. In the next 5 years, things are going to be incredibly different than they are today in terms of how we're actually treating patients and how we're actually using technology. Technology to date has really been, I think, a hindrance in a lot of ways. EHRs are very difficult to use. A lot of this AI technology will actually be helpful and stuff that we want. But I think there will be very slow adoption because I think health systems are very are going to have some issues around sort of implementation, and this is going to be slow adoption. But once this really scales, I think this is going to be transformative. Next is around care transitions. Care transitions is, again, many issues around care fragmentation, navigation issues, technology integration, EHRs, the total mess at this point. There are so many problems when patients go from, leave the emergency department, go to other settings. Many things that we can do around care transitions. There's and the reason for that is because it's such an incredibly broken system that really doing, I think, anything around care transitions and trying to systematize that, can be effective. The example from Kaiser is they actually do callbacks on all their patients. So after they leave the emergency department, 100% of those patients are getting called back. There are some technology solutions out there. Our company has what's called our ADAPT program, where we do text messages, emails to people, and try to get a net promoter score, some feedback, and then figure out whether or not people have trouble with follow-up. But again, this is another area that's just ripe for innovation. This transitional zone where there's a lot of inefficiency and patients that don't have a lot of guidance. So when it comes to where do I start, this is really a question, and this was about 12 years ago. I was giving a symposium with the SAM around crowding interventions, and it was mostly researcher. I was a researcher at the time, and I asked Randy Pilgrim, who's the emergency physician leader at Schumacher Clinical Partners, to get up there and tell us some stories about how you actually improved crowding in the emergency department. And he got up there and sort of blew my mind. And he said, it wasn't necessarily about sort of what they did. It wasn't like this thing always works. It was really about sort of having the right strategy in place, having the right people in place, because it's often, it's having an individual in place who can really makes it their job. People like Dr. Phelan there who do quality improvement work and can really sort of drive the local practice, having very specific goals, having measures, having analytics, and having a supportive environment. And again, without these approaches, it's incredibly hard to do innovation in healthcare in general. It's even harder with hospitals. I like to say that my observation is that the more people within a health system that have chief in their title, the harder it is to actually innovate in that health system, because it's harder for that organization to make decisions. But again, if you're, there is so much that we can do, and it really, I think the way to think about it is from the patient perspective. What are some areas, these very large inefficiencies that we can address? So a couple takeaways from this. There is, we deliver acute unscheduled care unlike any other country. If I was critically injured in the middle of the night, I would, love to be in a U.S. trauma bay, because we do a fantastic job. That is something that our country does better than others. But there's so many fundamental problems, and that's really where innovation comes in. And I, just the last sentence here. I mean, I think that it is great to see many innovators here. There's so much that we can do, but we've got to have the right approach, and we've got to realize that picking the right problem, coming up with a good strategy, having a supportive environment, and also having leadership input is really what it's all about, and leadership support in terms of being successful. So with that, I don't know if I take any questions, but thank you for your attention today, and I appreciate it, and have a great conference. All right.
Thank you so much for
Sure. Yeah.
joining
Do
us.
it.